Okay, well, why don't we get started again here? And we're talking about muscle diseases. So, Sahar, why don't you start with this one?
Okay, 52-year-old female, right hip pain, slip down, alcoholic drinking, tranquilizer, CK is pretty elevated, creatinine is high. There's increased signal in the right gluteus maximus, so there might be hemorrhage and or grade 1 to 2 sprain of the muscle. There's extensive subcutaneous soft tissue edema also.
Yeah.
So maybe a combination of like muscle sprain and rhabdomyolysis.
And here's some more images.
Okay, so again, we see some asymmetric increased signal in the right hemipelvis and posterior thigh muscles.
A lot of the areas that are not perfusing. So again,
Sorry, Dr. I don't know, I cannot hear you very well. I don't know if it's my problem or my phone.
let me just check here. There is some feedback here. Let me just see. There we go. That's good. So what we see is all this edema, swelling, and then we have these large areas that lack perfusion within the muscles. So this is all typical of rhabdomyolysis. And the patient is a typical setup. Alcohol, which breathalyzer probably fell. A lot of these people may be down for extended period of times with pressure on a compartment, kind of compartment syndrome. And then this patient will have renal failure from the rhabdomyolysis. Yes, somebody has their mic on. There's some background noise. If they could turn it back off again. Thank you. Okay, Thomas.
Left thigh pain for 1 day in the ER, diabetes, cholecystectomy, coloduodenal fistula with pneumobilia, liver abscess, CK 3000s, myoglobin 1636, LDH, BUN, creatinine is a little bit elevated. So axial view of the femur, there is extensive edema of the rectus femoris, vastus lateralis, I think, and intermedius, and then fluid and edema around the muscles. So this could be throughout the left quadriceps, diffuse edema. This could be rhabdomyolysis of the thigh.
Well, let's go back here for a second. This patient had a coloductal fistula with pneumobilia and has a liver abscess.
Oh, okay. It'd be infectious. The myositis.
Yeah, this was 2 organisms which grew out of this. He probably had septicemia from the infection from the GI tract.
This is a cachectic 55-year-old with weakness. Just wasted away musculature. And 58-year-old with weakness.
Actually, going back to what before, this is again the muscular dystrophy syndrome, right? Typical symmetric posterior part of the legs, fatty atrophy, and elsewhere. This was monochondral.
Back surgery too.
Yep. Mutation.
Okay, severe crampy muscle pain 3 days after Ironman competition. So there's a little bit of edema within the medial gastroc there. It looks a little more prominent there.
Still kind of striated, feathery appearance, just seeing a grade 1 type injury.
Yeah. So given that he was just in a competition, I would suspect DOMS. Yeah, it looks like there's a little bit more higher up. The medial Yeah, they're sort of just scattered all over.
It's maybe a little bit more on the severe end of dogs.
Mm.
Yeah, there he is. I don't know. Probably not. Yeah, right, exactly. And then we can see peripheral nerve injuries, but we're going to talk about this in a minute. Let me just do another. This. We'll do this. Well, we'll have we'll have more of a lecture on nerves in just a minute. What do you think of this one?
Okay, so history withheld, and there's a plain film, one view of the pelvis, frontal view. Looks like osteopenia. It looks like I think the acetabular coverage is not complete, and then there's also a coxa valga bilaterally. So I wonder if this is congenital. This X-ray of the
That's a coxa magna.
coxa magna. Okay, with the coxa valga, and yeah, it looks like enlarged femoral head, sir. And this is a lateral view of the elbow X-ray, and it looks like there's a ossification between the distal humerus and the radius. There's scoliosis in this chest X-ray. I think the ribs are deformed, and there's some increased density of the ribs. Looks like it could be a syndrome.
Yeah, it's a dysplasia.
Okay, fiber dysplasia ossificans progressive.
Yeah, called the Stoneman syndrome, where they get a lot of ossifications throughout the skeletal system. It's another chromosomal autosomal dominant mutation. Okay. Alrighty. So
They used to call some of these the 4P syndrome, or maybe 5P syndromes.
what do the P's mean?
I'm not going to say it on since you're recording.
Alrighty. Okay. Well, let's go on and talk about some about nerves. So here's a case. Who's next? Okay.
They probably don't talk like that at Harvard, John.
Oh, okay.
Okay, so coronal and axial images through the abdomen and upper pelvis. So it seems like left iliopsoas muscle has been replaced, fatty change. Yeah. So yeah,
What does that look like?
I mean, fatty replaced, look like a lipoma, but
Okay. So there's got a lipoma there.
right. And the muscles are also.
So this is on 2/22/2017.
Mm-hmm.
And it looks pretty uniformly fat. Looks like a pretty benign lesion.
Right.
Isn't that gas?
This is fat, John. Gas is the black structure over here. So this is actually a lipoma within the muscle.
Oh, okay.
This low density material all through here is fat, and subcutaneous fat here. Okay. So now the patient came back a couple of years later, and this is what they
Okay, so I see the fatty replacement of the muscles. I don't see that lipoma here.
Well,
yeah, we are too low. Sorry, yeah.
So we're in the legs now.
Right, yeah.
You see that there is a lot of
fatty infiltration.
Yeah. On the left side, very asymmetric.
And symmetric.
Can't see any surgical clips either.
Yeah, well, I think we're below the level where the lipoma was. That was up in the pelvis area. But we can see what we have distally now with left pain and weakness. We have a significant.
Get closer to the mic, John.
Okay. So we have a lot of atrophy here on the left side. in the area where there's pain and weakness. Here's some more images.
Okay, so on the left side again, I can see the atrophy and the fatty replacement. So yeah, the left side, lots of fat. I can tell that, and some. What is that? This is the nerve. Yeah. Is it a femoral or?
It's a femoral nerve.
Femoral nerve. Yeah. So it's increased and increased signal.
These are more cuts.
Right. So, right, enlarged and increased signal. So it's probably normal. So it's a neuropathy or nerve-related issues.
Okay, so let's keep going.
It's increased in size, signal. Yeah. Neuritis.
Here's the psoas muscle.
Yeah, which is.
Here's the next cut.
Wow, there's a big one now. It's thick and enlarged.
So this was the area here where they actually resected that lipoma. The sagittal images.
Yeah, this is a nerve. You can see it.
The right side.
Right.
And here's the left side.
Right. So then, like, I think they resected the nerve accidentally.
Yeah. So when they removed the lipoma, they actually cut the femoral nerve, and then you can see the distal atrophy from lack of innervation.
Why did they remove the lipoma?
That I don't know.
Where's the neuroma, or is that recent?
Say that again, John.
You would get a neuroma with time.
That's what.
But if this is recent, then you wouldn't see it.
Yeah, no, I think the surgery was I think a year or more before this.
Then there should be a neuroma someplace.
Which is right here. That's what this
is. That the neuroma?
Yeah, that's the neuroma.
Oh, okay.
Okay. In the actual image, there was some on the thigh. There was some hyperintensities.
I thought that was the nerve
around the femur.
Yeah, that's the distal end of the nerve, which becomes bulbous, and a lot of people call it a neuroma.
I see. Distal.
Okay. So here, if we go back here we can see there's the femoral nerve here on this side, and that's a normal one on the other side. And if you follow it down, you can see it gets thickened and big and edematous, which is what the distal end of the resection.
Got it.
So proximal and distal, they get thickened.
Really, the thickening is more proximal. The distal can also, but it's more proximal.
I see.
Okay. And then this is the sagittal images where you can see the two sides. Here would be the distal stump of the femoral nerve, the neuroma. This is what the neuroma looks like on the opposite side.
And this was done surgically?
Yeah, the only thing John, the only thing I know is that the previous studies showed that there was a lipoma there, and it was resected, and now the patient comes in a couple of years later with the atrophy and the pain in the leg.
Got it.
Yeah.
Well, it's pretty interesting that they would dissect a nerve that size from a lipoma. Geez, that's careless. That's pretty careless.
Yeah. Okay. So now let's go on to sciatic nerve injuries. Everybody's heard of sciatica. We talked a bit about it when we talked about lumbar disease. Sciatic nerve injuries are thought to be due to stretching, laceration, or compression. Usually the stretching or compression, a lot of people think they come from disc protrusions of the nerve roots before it, but also you can get compression or stretching of the nerve root in the area of the psoas muscle, the piriformis muscle. And so there are a number of different names associated with pain that may be due to the muscles compressing or stretching the sciatic nerve, and then obviously laceration. When you talk about nerve, the different kinds of, there have been a number of different nerve injuries, and they've got these crazy names, and we'll see this kind of over and over again. A lot of people like to take like neuropraxia, axonomesis, and neuronomesis, and use these words. Personally, I don't think these words should really be used very often in a report. Remember, now patients are looking at reports, and a lot of radiologists are getting a lot of criticism because when patients read the reports, the terminology is such that the patient can't understand them. And I think a lot of doctors don't understand a lot of the words. But neuropraxia, really, you get a conduction block at the area of the injury to the nerve. Axonomesis, you actually get a division of the nerve fibers, and neuromesis, you actually have a transected nerve. But we'll talk about other grading systems along this line going forward. When you look at the anatomy of a nerve, you have the epineurium that encases the entire nerve. Then you have the endometrium that are around different fascicles within the nerve, and then you have the nerve fibers within each fascicle. So the nerves have this kind of a complex arrangement. Another way to look at it is this, where you have a single axon. Around the axon you have a myelin sheath. Around the myelin sheath you have an endometrium, and then around this nerve bundle you have a perimetrium, and this would be a fascicle. And you have
endometrium, John.
Oh, endoneurium. I'm sorry. What did I say?
Endometrium.
Sorry about that. You're right. Good. I'm glad you caught that. And then fascicles, and then we have multiple fascicles, and then the nerve down the middle of it, and then the epineurium around the periphery. So, and there have been several classifications that have primarily looked at sciatic nerve injury, but it's generalized really to all nerves. One is the Selden classification, and the other is the Sunderland classification. In the Selden classification, you have neuropraxia, which is the lowest grade of injury. You have local myelin damage, and it's usually from a compressive injury to the nerve. And in the Sunderland causes this a grade 1. The next one is axonomesis, and Sutherland has a grade 2. This is where you have severed axons, but the endometrium is still intact. So you get
misspelled.
It is misspelled. Endoneurium. Excuse me. That's crazy. That was a bad mistake on my part. Both.
I almost went into gynecology, John.
Oh, well, it looks like I did. Okay. And then another level of axonomesis, which with Sutherland would be grade 3, as you have discontinuity of axons, as well as part of the discontinuity of the tube, the perimetrium, and the perineurium, and the fascicular pattern is preserved. And then another grade 4 would be loss of continuity of the axons, and then you have injuries to the turbine, to the tubes and the perineurium. And then neuronomesis is just a complete resection of the entire nerve. Classically, you evaluate...
John, that classification is for all nerves, I think.
Yes.
You have it labeled sciatic nerve, I think.
Yeah. Well, this has been best evaluated in the sciatic nerve, but it's for all nerves.
Okay. All right.
Classically, when you evaluate nerves, it's you look at nerve conduction velocities and electromyelography, but it's not reliable early on in injury to the nerve. It's really only reliable for more chronic lesions. and the physical examination is really not good at differentiating high-grade from low-grade lesions. So, and as far as treatment, if you have the low-grade lesions, which would be the early grade of the, typically is conservative treatment. So if you just have the local damage where the endoneurial tube is still intact, wow, this is bad. Intact, as long as the tube is intact, then it's typically treated conservatively.
Yeah, that penurium, if that penurium is intact, you watch it.
Yeah.
And it takes 1 millimeter a day, so it's a long wait.
Right. And then if you have more of the grade 4, where you have discontinuity of the endoneurium, but the epineurium is still intact, or if you have a complete transection of the nerve, then these are two that may require surgery.
They do require surgery.
So, and trying to evaluate the high and low grade lesions on an MR examination, what you have a number of findings that you can look for. You look for nerve size, T1 signal, PD fat sat signal, T1 heterogeneity, and heterogeneity of the protein density fat suppressed images. But it turns out that these findings, though they're more common in high-grade lesions, are not helpful really in differentiating high from low-grade lesions. The findings which are more helpful, if you see perineural fibrosis, if you see architectural distortion, and the appearance of the nerve, bulbous enlargement of the end of the nerve, like we saw in that case, complete discontinuity of the nerve, and then if you get skeletal nerve denervation, then these are all present in high-grade lesions, which typically are lesions where surgery may be helpful. So these are the 5 things you really look for in trying to determine whether surgery is indicated. Now, there are more sophisticated ways of looking at nerves that people are beginning to look at now using diffusion-weighted images. And here the concept is that if you go back to the nerve fibers, what you have is rather free-flowing fluid longitudinally within the nerve, but all these membranes inhibit transverse movement of fluid. So the more severe you have injuries to these endoneurial sheaths, then the more you'll get transverse movement. And then if you have destruction of the perineurium, then you'll get a lot more transverse diffusion. So a lot of people now are looking at, especially three-dimensional or tractography diffusion to try to help differentiate the different lesions. So you can look at ADC values, which we look at often in the brain, where you just look at the amount of signal loss that you have when you put on different gradients. And the more diffusion you have, the more signal loss you're going to have. So it's an indication, the more signal loss, then the more diffusion you have. So if you have, this really is a measure for extracellular fluid. Another thing to look at when you use diffusion tincture type imaging is you can look at, very similar to this would be the mean diffusivity, where you actually take the diffusion in three directions along the nerve and the 2 directions perpendicular to the nerve and average those, and you get something similar to an ADC, where you're not acquiring the images along tensor directions. With ADC, it's just a global measurement, but when we start looking along different directions, then we can average that to get a similar amount. Or you can actually look at fractional anisotropy, which is how much of the diffusion tends to go along the axis versus perpendicular. And typically, and this is an index of fiber disorientation, so typically what you would have is a lot of fractional differences because you have a lot of flow along the nerve, but not much side to side. If that starts dropping, then what it means that you're having less longitudinal and or more side to side, which means that you have more damage to the nerve. And people are looking now to see whether this number can help be a reliable determinant of the severity of the injury to the nerve. And there's still a lot that needs to be done to determine quantitation of this. And then this would be parallel diffusivity. This would be the amount of diffusion going along the axis, and this would be perpendicular diffusivity, where you're going along the axes which are not perpendicular to the length of the nerve. So there are a lot of numbers that can be determined now with diffusion type imaging. And you can actually put these in a matrix where these different numbers, and if you look at the different levels of abnormality within the nerve, you can actually use these numbers to try to differentiate whether it's a high level injury or a low level injury. But again, I think this needs to be validated more, but there are a number of studies now showing that this looks like it may be a more accurate way to evaluate the extent of nerve injury than using the traditional methods. Now, when you have surgical techniques, if you just have scar tissue around the nerve, which can stretch or compress the nerve, then you can do a neurolysis and release the scar tissue. So if you see kind of nerve entrapment on an MR scan, that may lead to a neurolysis type surgery. If you have a clean cut of the nerve and there's a gap of less than 2 centimeters, then surgically you can put the two ends of the nerve together and hope that they kind of fuse and you regrowth a nerve along from the proximal nerve down through the distal nerve and regain some neurologic function, and that's called neurography. With a larger gap, then you can actually put in a nerve graft where you take a less important nerve from somewhere else in the body and put it in between the two gaps and then try to hope that the nerve can grow on.
You can do more than 2 millimeters if the nerve damage is at a joint, like in a flexion area, like the elbow or whatever, or the knee. So you can get away with more than 2 millimeters. Or is that 2 centimeters or 2? Yeah. Oh, 2 centimeters. Yeah, well, that's about right.
Yeah.
Sorry, I thought it was millimeters you were showing.
I made another typing error.
Okay.
Yeah. Yeah. And the last procedure is called neuronization, where basically you take a less important nerve somewhere else in the region and take that nerve and redirect it to the more important nerve and then connect it to the distal end of the nerve and have it re-innervate the area of importance, and the brain can reprogram itself to use the other nerve to perform whatever the essential function is. But again,
you have to pick a nerve that will do that. Not all nerves will do such things.
Okay.
It's very interesting how the nerves are very, very different. Like the radial nerve and the ulnar nerve and medial nerve are quite different in terms of repair and how they react to the repair. So you can't really use these type of analyses and so on, and use them on every nerve in the same way. Because they're all different.
Right. Okay. And then people are now looking at the use of diffusion tincture imaging and evaluating the regrowth of the nerves with the different surgical techniques. But I think there's there's still limited data concerning the value of diffusion tincture imaging and evaluating these, but I think it's rapidly being gained. So kind of to go back to it, the Sutherland grades, the Selden types, neuropraxia, axonomesis, and neurontomesis, that you can divide these up into a number of different categories. And remember that the lower grades here typically are treated conservatively. The higher grades may benefit from surgery. Now, there are some common sports nerves injuries that are characteristic of different sports. Baseball, common injuries are suprascapular nerve injuries from repetitive stress, axillary or quadrilateral space injuries, usually from direct trauma, and that may be a reason why baseball players not infrequently will have teres minor muscle atrophy, and then the ulnar nerve at the cubital tunnel from overuse injuries of the elbow. In cycling, there's compression of the ulnar nerve at Guillen's canal in the wrist, the median nerve also in the wrist, and the pudendal nerve from stretching from the seat. Yeah, and this can be a real pain in the ass. I've had that before. And then running injuries, we're all familiar with Morton's neuroma, which is thought to be due to stretching from push-off. Could also be compression between the metatarsal heads. Running the tibial nerve, compression at the ankle, and then also running jogger's foot, which we talked about with the medial plantar nerve, compression distal to the calcaneus. Football, we've all seen it watching NFL. They get stingers, typically from a forceful stretch injury to the neck, stretching the nerves in the neck. And in skiing, you can get a femoral nerve, both proximally and distally, as well as the ulnar nerve from the poles in the hand. Tennis, radial nerve compression during serving, suprascapular nerve also compression during serving, and then weightlifting, the medial pectoral nerve from compression from nerve hypertrophy. Let's just kind of go through what we talked about. There are a lot of different ways that they can present, and then you have to determine the severity of the injury. Usually with sports injuries, they're at the low end, and they're almost always treated conservatively unless there's traumatic injury to the nerve. Okay, well, that's just a little bit of nerve injuries. It's not quite as detailed as some of the others because we don't have as much experience in evaluating nerves here as we have in evaluating a lot of the other injuries. But as time goes forward and we get better diffusion tensor imaging techniques, I think we'll probably do more nerve imaging in the future.
One of the things about electromyography and using that technology is the neurologist or physiologist, they really have to be knowledgeable and interested in what they're doing. My experience in the past has been that most of them are not that excited about using that technology, and ergo you don't really get very good, accurate results in some cases, maybe even more than some.
Yeah. Yeah, well, I've had some involvement both back when I was a clinician and then in following some of the patients with orthopedic surgeons as a radiologist. And I think people use electromyography because that's all that people have had in the past. And I think there are a lot of limitations. It's not clear that MR is good enough to replace it yet, but I think there's a lot more strides that may be performed over the next couple of years, and we'll see. It has some potential, but I don't think that's been completely realized yet.
I've been disappointed. There was one guy in Santa Monica that I remember that I always send my cases there, and I could plan on a good read.
Okay, good.
But he left Santa Monica and now he's deceased. So I don't know if we have anybody really that great. I just don't know.
Okay, great. All right. Well, thanks everyone. I think that's everything for today. And Thursday we'll meet there. I could talk about